Yeah. It's and their birthday at the same time. Yeah. She- Okay. Everybody ready to go? 5 o'clock? Very good. All right. I'll call this regular meeting of Kittitas County Public Hospital District Number 1 to order. Thank you for coming. It is May 23rd, 2024. Bob Davis won't be joining us tonight. Mandy, do you need to do a roll call or anything?
Good, thank
Okay,
you.
we're all right. So we have the agenda. Any changes to the agenda? Hearing none, do I have a motion to approve the agenda? To approve. Okay, motion from John.
I'll second.
Second from Terry. All those in favor of approving the agenda, please say aye. Aye. Consent agenda, minutes of the last board meeting, the approval of checks, the foundation report, and the finance committee minutes. Any changes or anything to be pulled from the consent agenda? Do I have a motion then to approve the consent agenda? Second. Motion from Erica, second from John. All those in favor of approving the consent agenda as submitted, please say aye.
Aye.
All right, thank you. Now it's time for public comments and announcements. This is a public meeting and we have a time for people who want to make comments to the board. Please keep in mind that we don't respond to comments during the meeting. And please try to keep your comments to about 3 minutes and begin by stating your name and where you're from. Is there anybody here who would like to make a public comment or announcement? Okay, no public comment or announcement. Before we get to our presentations, Julie would like to make an introduction.
Yeah, and actually, I'm gonna pitch this back to Ron to introduce Wayne Tibbetts, our
Yeah.
new chief of facilities.
Wayne is my replacement. And so he just started Tuesday. He had the privilege of starting the same day DNV came, so. Some baptism by fire. But yeah, so he has just jumped right in and has a really good background, and I think he'll do a fine job. So,
Good to see you. Wade. Do you want to say just a couple words about where you're coming from? And
I'm originally from eastern New Mexico and West Texas. And this was an opportunity that I wanted to follow up on, partly for everything I've read about this hospital and also for the area. So it's been great. And as far as DNV and baptism by fire, I'd like to say everything that it's been so different, that everything has been well taken care of. And, you know, there was very few incidents of findings or anything like that. And so I appreciate Ron for being able to step into something like this. So it's great.
I feel so fortunate to have the overlap that we do between Ron and Wayne, so that Ron is running the roads. and-
Modified trauma, ER triage, modified trauma, ER triage.
Busy down there
They're
today.
busy.
So really looking forward to Ron showing Wayne the ropes. And on Tuesday, when you take your tour and get the update on the facility, Wayne will join us for that as well.
welcome.
Welcome, Wayne.
Thanks for joining us. All right. First presentation we have is a presentation of our Safe Catch Awards. I say this every time. This is one of my favorite parts of the job, seeing all the great work, learning about all the great work that our team members are doing. We talk about Safe Catch Awards at QI Council, and we had a great list of nominees. It's always a hard decision to make. But we have 2 of the winners here today with us. So let me remind you what a safe catch is. Safe catch involves at least one of the following. Catch prevented an event from reaching a patient or staff member. The catch prevented pain, delays in care, unnecessary costs, or workflow inefficiencies. The situation was high risk or had potential for greater patient harm, such as communication errors, surgical site infections, or falls. The catch led to frontline or just-in-time improvement. All right, so we have two winners tonight. First winner is for our clinical award. This is Kristen Caraveau, lab assistant from Lab Services. And the reason for nomination was using quick thinking to find a reference lab to send samples. So I'll read what happened. The patient had labs and then went to radiology for a spinal tap and CSF collection. These tests were to have plasma and CSF run in parallel for the detection of proteins to help diagnose Alzheimer's. These samples are considered irreplaceable due to the difficulty of collection, and we keep an additional sample in the fridge just in case. We received a call informing us that the VDRL would need to be recollected as the original reference lab disposed of the samples in error before completing the ordered tests. We offered to send the additional sample, but too much time had passed for the reference lab to process the sample. Thanks to Kristen's quick thinking and decision to look for other reference labs to run the test, she was able to send the saved sample to a different site to save the patient from having to be recollected, and we were able to successfully complete all required tests. So saved someone, among other things, a spinal tap, which is good to do.
Not comfortable.
Yeah, right, not fun. So thank you very much, Kristen, and congratulations on winning our clinical award.
Thank you.
A non-clinical award goes to Sarah May from our housekeeping supervisor in environmental services. The reason for nomination was following up when isolation signs were removed. So it was noticed that at times when isolation patients are moved from one room to another, the isolation signs were being taken down prior to room cleaning. Sarah followed up with staff and provided reminders to leave up isolation signs so that housekeeping is aware of precautions to take and the room can be cleaned properly. Thank you very much, Sarah. As we say all the time that as part of this award, they're being recognized. There'll be a banner in front of their right. Yes, in front of their departments. They get a charm for their pendants and they get a gift card. So thank you for the wonderful work you do. And thanks for coming to the meeting.
Thank you for watching it.
We're gonna, Jerry and I, as members of the QI Council, we're gonna step out for a moment and have our pictures taken with the big winners.
Thank you guys, appreciate it.
All right, so we'll move on to the second presentation. We've got Tom and Daniel from DZA, and we're going to be reviewing the audit for this last calendar year's financials and so forth. So Tom, you want to take it away?
Yes, thank you. Hello, everyone. And Daniel Duchai is here with me as well. He was the one that led the audit. And we also presented earlier this week to the Finance Committee. And so this is the second presentation of the audit. So we'll probably went a little more in depth at the Finance Committee earlier this week. So please ask questions along the way. I'm going to share screen here and get going. And I think everybody can see where we're at there. Start with, you're situated here a second. So just who DZA is, we're a CPA firm physically located in the Spokane Valley, Washington. We have employees and clients, all over the West, and work with hospitals and other healthcare organizations throughout mostly the Western United States, but kind of into the middle of the United States as well. Audits, cost reports, anything related to what healthcare and not-for-profit organizations want, very specialized in that regard. Work with the 75 or so critical access hospitals, 7 partners, 60-person CPA firm specialized in healthcare. Quick little intro there. Agenda, going to go over a couple reports as part of the audit. Obviously, the independent auditor's report and the audited financial statements, hit the audit reports and the key points, and then a few financial indicators that help put the district's, the hospital's financial position, kind of a more graphic, visual representation of financial position and results of operations. And so kind of jumping right into it, I have the PowerPoint presentation that hopefully you guys can see. And then I'll also give page numbers along with the financial statements if you prefer to follow along with the financial statements themselves. I think the PowerPoint will suffice, but different styles. So a couple pages into the financial statements, pages 1 and 2 is the first of the 2 independent auditors reports. It's an unmodified opinion, which means that the financial statements that follow present fairly the results of operations and the financial position of the hospital. There is an emphasis of matter this year, and we'll kind of touch on this a couple places along through the presentation. There was a new auditing standard this year for subscription-based IT arrangements. It applies to governmental entities in general, but certainly has even more specific applicability to healthcare entities that happen to be government entities as well. And what it does is when you have a non-cancelable agreement of more than 1 year for IT arrangements, such as Cerner in your case, and you have that commitment, a right to use asset is recorded on the balance sheet and a corresponding subscription liability. Very similar to the leases that were recorded as assets and liabilities last year. So it kind of really follows up with the same principles in that. And we'll see that here in a couple slides, what that did. It affects net income a little bit, in that there's a little bit of difference in timing. And with, like, say, Cerner, you were paying a monthly flat fee to it. And so now the expense doesn't show up as a purchase service. It shows up as interest, broken down between interest and depreciation. Depreciation's level over the term of the agreement, but the interest is a little more front loaded. So it has a little bit of an effect on net income, but nothing significant. It mostly impacts the balance sheet. So kind of jumping ahead to the next page is the asset part of the statement of net position or balance sheet. We'll come back to the cash and cash equivalents and some of those, and the patient accounts, the cash and cash equivalents for pretty soon, and the financial indicators. Patient accounts receivable, you can see about a little over $16 million of patient accounts receivable outstanding at the end of the year. And that represents 47 days of patient revenue, kind of right in the expected range of that for where most revenue cycles are, and in the 30s and the 40s of days outstanding. The next line down is I'm not going to go through all the lines, but so just don't get worried about that. It's not going to be that long a presentation. But the estimated third-party payer settlements is your Medicare cost report receivable for 2023. It as a critical access hospital, you're paid interim rates for inpatient, outpatient, skilled swing bed, and to a lesser degree, rural health clinic services. Medicare pays those interim rates through the year. They attempt to true it up a couple times a year, but at the end of the year, there's always going to be some payable or receivable as it gets converted to actual cost. This year, it's about a $1.3 million receivable from Medicare to true up the cost. And receivables and payables don't really indicate anything good or bad. It's just literally the true up between the interim costs and the actual costs and cash flow. Couple other lines, there's cash and cash equivalents restricted for bond agreement, the $9.8 million, the money set aside for the expansion project, remodel project that was still unspent at the end of 2023. And then your investments internally designated for capital acquisitions of a little over $37 million of your money set aside for capital. And then the liabilities and net position. And the main thing to point out here is those new lines. You'll have the subscription liability net of current portion of about $3.5 million, and then a current portion of another $822,000. That's the new liability that went onto the balance sheet this year related to the agreements with Cerner, and then also a smaller one with Change Healthcare that's on there. I'm going to go back a page here, is the corresponding right to use asset that's about the same amount is included in the capital assets. So that $4.3 million of liabilities also has an asset of about that size that was added to the assets as well. So that's a change in the liabilities, and I have a couple later slides where we'll hit that a little more detail. And then the other post-employment benefits liability, just point out, and that's the liability and also this deferred inflow related to the healthcare insurance you obtain through the PEB, and because there's some obligation for retirees' health plans accounting standards require that obligation be recognized during the service period. It's actuarial and an interesting calculation, but it is what's on the books for the second year, and as long as you have the PEB plan. Going into the operating results, net patient service revenue increased 6% with continued growth in what you do and the services you provide. Salaries and wages increased 9%. That, and also, kind of corresponding that purchase services decreased as you did use less contract labor. So there was a movement from the contract labor to the employee base. Professional fees increased with some increase in some physicians groups you're using for OB and ER. So in the end, expenses in total increased 8%. And you can see the difference between what you got paid to provide healthcare services and what it costs to provide healthcare services. Your operating income of 3.2 million compared to about 5.3 million the previous year. So a positive operating income of sustainability there. And then the non-operating results, not directly related to providing healthcare. Investment line, you can see last year it was a loss, this year it's a gain. Your interest expense, which increased with the subscription liabilities. And then last year, 2022 was the last year of the COVID relief and any kind of COVID funding that came through the organization. And then you're changing that position of a positive $5.2 million or net income of $5.2 million compared to $6 million in the previous year. And I'll kind of come back to those couple slides with the financial indicators as well. And then the statement of cash flow showing that the cash generated by operations was $7 million, a little over $7 million in 2023 of a positive cash flow that then flows in along with obviously bond proceeds into your capital replacement and use of debt service payments and then capital asset acquisitions. Any questions at this point?
Any questions? Jason or Julie, you have anything you want to fill in? Or
Nope.
I think we're good. All right.
All right.
I think we're ready to proceed.
All right. And then going into the next part of the financial statements are the notes, which serve three purposes of who you are as a reporting entity, where you're located, what you do, how you're governed. And then into the second part of the significant accounting policies, which provides explanations how different balances and transactions are recognized and reported in the financial statements. Good reading for how financial statements work. And then into the next part are the details of significant account balances and transactions or financial statement disclosures. And thinking of things that a reader of the financial statements would want to know more about. And audited financial statements serve a purpose for you as the Board of Commissioners, the governing board and management. They're ultimately designed for readers outside of the entity itself or the district itself. And so what would be important to somebody that's looking at those financial statements? The most significant, just going to hit the notes, not go through all of them. There's obviously quite a few pages, but note 6 is long-term debt. And you can see the top part is your revenue, mostly the revenue bonds, and no new revenue bonds or debt during 2023. Just their normal scheduled payments, then some lease liabilities. A few of these were recognized for the first time last year, no new lease liabilities. And then you can see that the subscription liabilities, the new accounting standard liability for the Cerner and Change IT arrangements was recorded at just a little under $4.9 million as of the beginning of the year. And then the next couple slides show just your annual debt service. This is just the revenue bonds and your long-term debt of what debt service there is each year that comes from operations. And then the top part of this is your lease liability, debt service per year, and the bottom is the subscription liabilities, just information there. And then the next note, I think that's always kind of interest, is the net patient service revenue note that just shows where your revenue comes from. And Medicare makes up 42% of your net patient service revenue, Medicaid another 14%. So, that about 2/3 comes, about 56%, can't do the math on the fly there. A little over 56% of your revenue comes from Medicare and Medicaid, which are for the most part cost-based, not completely cost-based. And then your other third-party payers is your commercial insurances, and that represents 45% of your net revenue. And kind of a number that doesn't show up on here, but the commercial is 45% of the net, but commercial patients are 36% of your gross revenue. So they're a little over a third of your revenue, but then they end up of your patients, and then they're about 45% of the revenue. And it highlights how important commercial patients are to the overall profitability of the organization. And then, moving on to the second auditor's report, which is on page 34. And as a public hospital district in the state of Washington, you're required to also have the audit performed in accordance with government auditing standards. So this is the second auditor's report, where we report on internal controls over financial reporting and compliance. And the important takeaways, one of the important takeaway of the audit is no material weaknesses are reported and no significant deficiencies are reported. So no findings. And we do report findings in audits, probably at least half. And so it is significant that there are no findings or material weaknesses reported.
So who do we have to thank for that?
Jason and James.
All right.
Yeah.
Thank you.
Mostly James.
Yeah. And then any questions on that? And I can kind of just then jump to the financial indicators, and that's the official auditor's report part of the presentation.
Any questions? All right, I think you can go on.
All right. And then just a few slides that show the some ratios. Total margin is what does that change in net position or net income relate to your total operations? It was 3.9% in 2023 and 4.9% in 2022. 2021 was an outlier for almost all healthcare organizations, with just the way things came out with COVID funding and the like. Generally, the goal, best practices, is being the 3 to 6% range from year to year for sustainability and having reserves and flexibility and capital acquisitions. And you are in that range, so that's very good. So, and then the operating margin shows it taking away the non-operating parts of your revenue and expenses, mostly investment return and interest expense, and a 2.5% positive operating margin compared to 4.4% the previous year. So still good spot to be. And then days cash on hand, how many days of cash could you theoretically go without new cash coming in and meet your expenses as they came due, your cash expenses? About 161 days. Generally, at least 90 is kind of the benchmark for the minimum you want to be for financial stability. And then, as you get into the 180 range, kind of the next goal around capital reserves as well. And I think as I done a couple presentations this week, the whole theoretically cash coming in is a little less theoretical with some of the cyber attacks on some of the revenues, the streams of money this year for some organizations. So a little less theoretical. So what those three slides all do is more graphically, more visually show the very solid, very good operating results and financial position for the district.
And Tom, I suppose you do a lot of these for a lot of different hospitals.
Yeah.
And I know a lot of hospitals in Washington State especially are being squeezed. So do you see a lot of negative operating margins?
So, working with critical access hospitals from kind of the smallest of the small, like literally $5 million of revenues to ones to your size and a little bit bigger, we are seeing, and kind of how I explained, same question in the finance committee, is wherever hospitals, this is a generalization because everybody's a little different, but wherever they were in 2022, it's not as good in 2023. And as kind of the same way you would look at yours, is like it was a little less, the margin is down a little bit, still good. In your case, it's good. And generally the bigger critical access hospitals are still doing okay. And the ones that, hospitals that were closer to break even might have moved into a loss position, and some of the ones in a loss position have bigger losses. So a slide generally to less to worse results, I guess is the way to say that. And dependent on where the hospital started to begin with, and from 21 and 22. It's kind of a
All right.
long, maybe on point answer.
No, that's all right. So you're seeing a lot of this kind of shape on their,
Yeah, it's yeah. 21 an outlier up, and then 2023 less than 2022. Generally, certainly every hospital has its own story, and every year has its own story. But Jeff, this shape, that's a good way to say that. This shape is pretty common on this graph.
okay.
Yeah.
Thank you.
I'll remember that for the next presentation. That's a good, it's a good words to use there to paint the picture. So that's the main. There's some other slides, and I was the third report that I went over in more detail with the finance committee. So I'm going to hit it really quickly in this, and unless you have some questions, but just things you'd want to know as the board and governance. It's just the accounting policies we already touched on, that there was a new accounting policy that did change significantly how the financial statements look with the subscription-based IT arrangements. Financial statements have estimates, the allowance for doubtful accounts and contractual adjustments with patient accounts receivable, the Medicare cost report settlements, and then the PEB actuarial liability. And why I kind of decided to go through this report is no difficulties in performing the audit. It did go very smoothly, and so that's good to know. May is in the right range of when you're getting your audit presentation. That's kind of a best practice. And then no material audit adjustments as part of the audit. Another good takeaway to know as a board and finance committee, that your auditors, us, are not coming in after the end of the year and making significant adjustments that change the financial results that you weren't aware of. Certainly some true up of some estimates and stuff, that's kind of part of the process, but nothing that we detected from our side, which is a good takeaway. And the other thing there, just talking about uncorrected misstatements, that technically the foundation is in accordance with government accounting standards, is supposed to be part of the reporting entity. Very common for foundations to not be included in a governmental hospital's financial statements for various reasons. And the foundation does get a separate audit, so it does have that accountability piece going for it. And then just
So Tom, the misstatement was just that we sort of didn't include them.
Correct. The misstatement is that the foundation should be part of the reporting entity. And so it's a pretty common to not include foundations within the reporting entity, is that the value's not deemed to be there. There's reasons to include and reasons to exclude.
Okay.
That's the only uncorrected misstatement.
Yep.
And then the areas that we focus on as auditors for the kind of the transparency of what the audit process is the first one, management override of controls, is always going to be there, is the things we look at, because that all controls can work. So there's always built-in audit procedures there. And then as a critical access hospital, the next two, the patient accounts receivable and the Medicare settlements, which from the couple slides before are significant estimates. And so those are always listed as areas we put more resources and more focus on. And then a new accounting standard of significance is also always gets some additional focus. Kind of said another way, it's whereas auditors, the things that if they did go wrong, they would make the most difference if they went wrong in the financial statements, is where we place that additional emphasis. So this is some added transparency to the audit process of just kind of where we put our focus. Not that these are the only things we look at, but those are certainly the most important things. Any questions?
Questions from the board? Anything? Yeah.
We do need to have the financial statements.
Okay.
But before you do that, I would again just like to, in all seriousness, thank Jason and James. That's a small crew that does a tremendous job. And when you think about the size of the accounts receivable and all the moving parts, finance hears every month about all the moving parts. And then that accumulating back and forth on the cost report that goes on all year long. We ask our board to rely on the interim financial statements as you make month by month decisions. And the fact that they're as accurate as they are is just really a tremendous asset for us. So we're making decisions with good information, and that's not always the case. But James and Jason do a wonderful job. And I would just also, with that tight crew that they have up there, remind you that they also do Hospital District 2, the foundation, and KCHN. So they are busy people. So thank you to them.
Thank you.
Thank you.
Yeah, Jason, would you mind passing along our thanks to?
Will do. Thank you.
All right, so any other questions or anything before we move to approve the audit? No? Okay, do I have a motion?
Move to approve.
A motion from John,
Second.
second from Erica. Any further discussion? Okay, all those in favor of approving the financial audit, please say aye.
Aye.
Anything else for us, Tom?
No, thanks for having us, and we'll have a good night and good rest of your meeting.
I know we always appreciate how clear your presentation is, and you make it easily digestible. I know there's a lot of work that goes into it, and it's very complicated, but I know I really appreciate your presentations every year. Thanks for doing so much work on them.
All right, thank you.
Thank you.
Good night.
Thank you.
Okay. Next up, we have Amanda Scott, our chief, our head of HR, and Dee Dee Utley, our CNO, to talk about some new requirements for the staffing committee. Go ahead.
Yes, so Dee Dee and I are doing this together, and I will kick us off. This has been an evolving topic with hospitals and labor unions for years, and we'll go over a little bit of that history. But the newest version of the staffing law is SB 5236, and it has a lot of different components we're going to talk about. I actually was nominated, I think, while I was on maternity leave, to be on the task force. So I'm on state representative. I'm a state representative for the task force, so that's been interesting. And I sit with several representatives, a lot of CNOs, some HR, and data analytics from some of the larger healthcare systems and critical access. And how it works is the task force is kind of the employer representatives that advises the advisory committee, and the advisory committee then goes to meet on this topic with the at the level with the unions to work out some of the compliance reporting systems and the forms and some of those things. So it's been a great experience. So the next slide, we will talk about a little bit more about what is involved in this. And really, in this description, the biggest change with this version is that it changes from a nurse staffing committee, which we have had previous regulations on, starting from 2008. And then some versions changed in 2017 that really focused on the staffing law. In 2020, when I got here, I think we really did a lot of education on missed breaks and tracking the missed breaks. So that was another version of a related law. But really, this big shift is changing from nurse staffing committees to hospital staffing committees. And Dee Dee will talk a little bit more later about what the staffing committee looks like and some of those components. But that was a big shift. And so again, this was kind of an evolving process, but it's really started with a discussion of mandated ratios. And so this was an alternative to mandated ratios with respect that all hospitals look different. They're different sizes, different populations. And so the focus of the work in this regulation is really about us being compliant to our own staffing plans. And so we'll talk about that a little bit more, but this is not a mandated ratio regulation. It's about understanding our own compliance. So with the next slide, we will talk a little bit about the timeline. So this is moving forward with some of the components that we have. So January 2024, each hospital had to establish a hospital staffing committee with expanded membership. We already had a really good process, and it was really adding some additional members to that. And including our Teamsters representatives. So we've been partnering with them, and there's a few additions and other details about that committee. July 1, we must file a charter with DOH, and we have a great template for that. Dee Dee will talk about that, and we're progressing on that. And then also a proposed staffing plan due to the CEO. October, hospitals adopt written policies and procedures regarding compliance with hospital staffing plans. January 2025, hospitals must submit their final staffing plans to DOH and annually thereafter. And then in July 2025, hospitals must begin tracking staffing plan compliance monthly. And this is now going to be through LNI. So that is going to be the regulatory body that's going to be monitoring compliance with some of the missed breaks and components and monthly compliance of our staffing plan. So monitoring compliance is a really big concern. Even some of the larger hospital systems that have some of the best HRIS systems and data analytics people are really concerned. There's just a lot of components to it and different ways that people are interpreting how to capture the data from the staffing plans. And then the missed breaks is a whole another component to that. But it is, I think, concerning of just logistically, how are we going to be able to capture and submit our compliance on this? And we also have different timelines as critical access hospitals. We have a little bit more time to work those things out, but people are starting to get a little concerned now. And so I'll hand it over to Dee Dee to talk a little bit more about the our progress.
Yeah, so as Amanda had mentioned, we did have a very well-established nurse staffing committee that I've actually been a part of since I started, and it's been a combination of the nursing directors, senior leaders, and then members of the nursing staff, basically the WSNA officers and their representative. And this is all covered in our collective bargaining agreement. So with this law, and we knew this law was coming, and so the nice thing was that towards the end of last year, we already had this committee in mind and started talking about it. So when we held our January meeting, we changed our name, at least, on the documents that we had in front of us. We invited the Teamsters rep, as Amanda had mentioned. They do have a PCT who's a representative now and is counted as one of our voting members. One of the other great additions, I think, was Jason having our CFO now attend these meetings. Because as we all know, that finance is such an important part of staffing and staffing plans. And I think Jason has brought, literally from that first meeting forward, he does a monthly report, some similar information that we share here, but he's also able to talk to the nurses kind of at their, that language where nurses are going to understand what those dollars mean. And I think you definitely opened their eyes and helped drive some conversation. We did have a co-chair. So I'm actually one of the co-chairs. I think the CNO has been just the co-chair at least as long as I've been here. And we're kind of changing that up, or maybe down the road, I don't have to be the co-chair. And we do have one of our WSNA nurses. And she attends the meetings, but doesn't really take an important part. And I think we're really starting to see that this committee is going to become much more collaborative, not just us giving them reports and, listening to the assignment despite objections, any of the staffing concerns, complaints. The staffing plans are the other important thing. And we have already, as a committee, gone through the staffing plans and are ready. We'll be submitting them to Julie by the deadline. The one thing that we have to do, we voted on them and they will then go to Julie, but we have to put them in this new uniform form that the template just was sent out. So that's kind of one of the next things that we're working on. But you can see these are some of the main responsibilities. And go to the next slide. This talks a little more about those staffing plans. So we've had these staffing plans in place for years. We have looked at them and we do voted as a committee of the staffing proposal that we would like to send on to the CEO. This is one part of the law that does change a little bit. And this algorithm kind of shows that we review the plans, we send them to Julie, and she is either able to approve them or can send them back to the committee with her written feedback. Then the committee comes back together, takes any of that feedback, hopefully comes back up with a good plan that we can send back to Julie for approval. If she chooses to reject that plan, then you can see what happens. We either go back what the staffing plan was in effect, last year, or whatever the last plan that's adopted. So there is still definitely some control, I think, when it comes to, final decision making and making sure all the right people are at the table here. And I think it also really challenges us as a committee to work together to collaborate to come up with a good plan that is right for the organization and right for the nurses, and when I say nurses, this is RNs, LPNs, and nursing assistants, and unlicensed assisted personnel. That is who this plan is really geared to at this point. So it's nice that we already have our plans voted on, and we have to have equal membership of clinical and management, and any vote has to pass with that 50% plus one. And right now, we're just working on getting them into that uniform form that we will be submitting to DOH, anything by July. And then next slide. So the charter, this is what we're working on right now. We've been meeting monthly as a team. We've extended our meetings. The committee has really been focusing on any of the complaints on staffing, those ADOs, assignment despite objections. We discuss those as a team, come to a resolution with them. The charter is what we're working on now. And our old charter was about 4 or 5 pages long. This new charter is like 16 pages long. We have a template that was provided to us that was worked on with members from WISHA and the 3 nursing unions. And we basically have taken that template and they've given us the guidelines to make sure that we're including all aspects of the law. And it gives us ideas of how we can personalize it to us. So we've had a subcommittee that's worked on the side, just because it's such a long document that includes both the nursing director, myself, and 2 of our staff nurses. And we should have that ready to be voted on for our June meeting so we can get it submitted for July. It's been a lot of work, but it's definitely, I think, bringing this committee to a higher level than it was before. I think everybody really recognizes this is a collaboration. It is not just, that us against them. We're not just, feeding reports. We're talking about and adding new reports. We're going to be doing some quality work. We're going to be doing HR. Obviously having the finance there every month is great. And then continue working on the meal and rest break, how we're going to be, we've got to get this out to the staff, tracking it, making sure that we're meeting the law, but we are also ultimately taking care of our patients and our staff. And just, a few other little things that are included.
Yeah, some other related topics,
Just
but I do have
little
to
things.
agree though. I think you've done a great job, Dee Dee, with making it, I think, really collaborative. And we did have an opportunity to do some performance improvement plans and brainstorming collaboratively with the committee. And it was a great opportunity to highlight. This is all the work we've been doing with recruiting and policy development. And so we actually have a plan now that's in writing that I think highlights all the work that we're doing, which is really wonderful. But the meal and rest break compliance is the area that I think, not that I'm concerned about that we're compliant with, but it is the tracking that I am a little concerned about. So, and other hospitals are as well. And there are just some unique things, like I think in the last meeting, our task force was talking about, we're going to need to start tracking not only missed lunch breaks, which we do have a system for in our timekeeping system, but delayed lunch breaks and things like that. So there are just some unique things with this new law and then also expanding some of our reporting on missed meal breaks and breaks to Teamsters and other licensed hospital staff, not just RNs. And so there are some unique things with that. And then really, I think there's a lot of work going on with our new staff development committee. And that's been run by Dee Dee's team and in combination with HR for organizational training updates. But floating and competency and orientation to the unit is a huge topic in the staffing committee. Is just how are we using all of our resources for nursing collaboratively across the organization to fill those needs. We've also presented some data like our sick call data, leaves of absence. So I think this new structure has allowed us to not just look at staffing as recruiting, because those are 2 very different things, but also just what does it take to, as the puzzle, that it takes all the directors and have supervisors to fill those spots every day. So I think those are big things. Another big component, I think, is mandatory on-call on overtime. We don't have that as a process here at KBH, so that's not something that we need to be concerned about with the law currently. But is there anything else you'd add for components? to that?
No, I think, the nice thing is we are already doing a lot of the things that the law is driving us to do, and we're ahead of schedule. That's my goal, is to be a few months ahead of any of these deadlines. Just today, I did have our WISHA rural CNO roundtable, and we did see a demo of a software system that I haven't even had a chance to talk to anybody about. Some ER nurse who has that, tech background has been working the last few years on developing a software system that helps to schedule the breaks, track them in real time. I don't know if that's something that we would jump on, but I do think there's going to be a lot of work, a lot of innovation and, technology possibly coming around, instead of us doing the paper tracking, which we do a lot of this paper tracking. And of course, our My Time does have some of it, but it's not going to have all the components that they're going to be requesting of us. And just on the next slide has a great resource. So WISHA sponsored this website, Working Together for Patient Care, and I would encourage you to check it out, or if anybody has questions, it's really written for the general public that addresses the staffing law, helps to answer questions. It talks about the timeline. It gives data, resources, and I can't speak enough for WISHA, because they've also, and in collaboration with WSNA, they've done multiple roundtables. They did a co-chair roundtable that Lynn, my co-chair, we were able to attend together. They are doing webinars, I know, for CEOs, CFOs, a lot on the filling out these forms. There's still some questions of how to do it. And I know if others are struggling, we will probably struggle too, but just lots of collaboration and people coming together, which has been nice. And then just happy to answer any questions. I know it's a lot of information, and I'm happy to talk offline also, if anybody has questions on it.
As it moves over under L&I's jurisdiction, what sort of penalties are we talking if we don't comply?
There's,
Do they seem like a very serious organization?
there are penalties.
Yeah.
I think it's like not till 2028. I mean, we have several
So there's some-
years to get there, but that is a part of it.
I think, and to go back to what the law requires, is that we have to be compliant with our staffing plans 80%.
80%.
And what's interesting is the hospitals are interpreting that all very differently. So in the task force, we looked at different models of how they're tracking that, how we could track that. Some we're interpreting more as a pass-fail system. So are we passing or failing 80% of the time? Some are calculating total hours worked on that day. And then it's, do you look at a point in time? Do you look at the whole day? There's just so many questions. And so it'll be interesting when people are doing it differently. This is going to keep coming back at as conversation, I think, legislatively, because we have to be able to prove that we're making progress and partnering with our unions to be able to deliver safe care to our patients.
So do you think clarity will come through legislation or through L&I? Or
at all.
or at all? Or we'll just wait and see.
I honestly think it's going to be the networking groups that we're in. I think the task force is going to end because a lot of the work is developing the forms, and but it's really going to be, I think, we need to look at this all together, I think, as an industry, and make sure that we're sharing our story, the challenges, and
We're still receiving interpretive statements. So there is still,
So you're trying to
No.
put moving targets.
right, exactly.
and a lot of these dates didn't really make sense when the law came out, and that this year was almost like a wash of a year, because that staffing plan doesn't go into effect till January 2025, that we've already voted on and we're ready to move forward with. We'll be working with Julie and obviously, our departments. The other thing with those staffing plans, we look at them routinely. It's not just a one and done. They do get a semi-annual review, and we know we can talk about it, at any time that's needed if we saw a drastic change. And we do make changes through the year. So I think, listening to some of my colleagues, we've got a good system here. I think we do have a great team at the table. We've always had the WSNA rep. Our Teamsters rep has attended every meeting so far. They either attend in person or Zoom. I think we have usually a full table of staff, and there's really good dialogue. And I think what I really appreciate is sometimes it's just sitting back and letting everybody talk. But still trying to keep control of a meeting and, but sometimes, even the staff are having good conversations amongst each other. And
And like Dee Dee, that's not what I'm hearing across the board from my peers. So they've worked very long and hard with this committee. It is very collaborative, and I'm really proud of the quality of the listening that goes on both sides. And WISHA for the last 3 legislative sessions has their top #1 job has been to defeat ratios. And that's where, it's a California style where it's 6-to-1, 6 patients, 1 nurse, that 7th patient, you don't have a place to put kind of thing. So cut and dried that come along with acuity systems and that are really difficult to manage. So this was the compromise of those kinds of proposals. And one of the reasons I'm so proud of the way we work together is hospitals have not behaved well in this. And this keeps coming up because we don't have that kind of genuine problem solving at every table. So I think we've done an exceptional job with this, and it shows in the give and take and the quality of the conversation.
Definitely, from what I hear, a hot topic across the country, and the collaboration and the proactivity here is just really incredible to be able to just merge into compliance with what we're already doing. It's really fantastic.
Other question? Yeah, Jerry.
Under the mandatory on-call and overtime, are we doing anything to help them if they need to have a little extra childcare because they're here working?
so we really don't do mandatory overtime. I mean, we don't. But if for example, like our OR staff, if they get called in and they're here through the night and they're supposed to work the next day, we have got a lot of triggers in place to make sure that they're able to go home and get the rest that they need. And that is all built into our current contract right now. So again, this is like a lot of this stuff, we're already doing it and we're ahead of the game.
Okay, thank you.
Other questions? Thank you very much, Amanda and Dee. Okay, we'll move on to reports and dashboards then. First up, we have Mandy Olson, our Chief Quality Officer. Mandy.
I apologize, I don't have my report. I have dashboards in there, but there is no ended report ahead of time. It's been a very, very busy.
Black or Mandy Olson. All it took was a couple of investigators and surveyors.
Well, and it started out with some other stuff 2 weeks ago. Holly Aprazo did resign her position. And we're sad to see her go. She's our risk manager. But we did learn a lot from having her be 100% remote. That really didn't work in this case, and that's where she resigned. But she was instrumental in setting up some events the week after she resigned. So last week, we had May 14th through 16th, we had Physicians Insurance here. They provided a lawyer, Rihanna Fronabel, to provide education to our providers about defensible documentation. And we had about 18 providers who attended that. And then Lisa Hamilton, their risk management consultant, provided training to our other clinical staff. So nurses, I think we had RT, we had some MAs. I think we even had a staff person from revenue cycle management attend and quality to talk about defensible documentation as well, kind of from their perspective. And then Lisa also did a risk assessment in family medicine Ellensburg and the pediatric clinics. And so that involved, it's kind of like a mini survey, I would say. And that involved touring the areas, meeting with leadership and staff, doing interviews, looking at our policies, our documents, and then they will provide a report to us about the opportunities they saw. And they did do a little report out with us about what they saw. And one, they had a lot of compliments that they gave the team They were really impressed with the barcode scanning that we have in the clinics and the Pyxis in the clinics. They said that's a best practice. They rarely see that. That was really incredible. That we provide aid training for all of our staff, that it's not just like the ER. That's what you see in other places. They were really complimentary of that. That the triage guidelines we have in family medicine, the mock code drills that have been being put on. So I think Shelley, the MA staff development or MA development coordinator, and Elena and Jamie Georgeson, the RN director for clinics. Okay, make sure I get all these titles right. They've been putting those on, and that was very impressive. That we have rapid response in our clinics. Yeah, even things like there's a label on the phones in the clinics to say how to page. They're like, it's surprising how many systems don't have that, and what a difference that makes in an emergency situation to have that. That we have strong reporting processes and follow-up to and investigation to events. And they said overall the clinics were well organized and clean, and they saw, no hazardous waste issues, no sharps issues, no expired issues, and no items unsecured like med rooms or medications. And so they'll get back to us with those opportunities. Just a couple things that they recommend related to offering chaperones for sensitive exams, and just some increased documentation. Not necessarily that we weren't documenting things that are required, but increased documentation that would decrease our risk. So for example, if you're consenting for a procedure, it's great, you must have, right, the consent, but it's also great if the provider documents that conversation in their note as well. So they had some really great feedback. They also, there was one thing they did see, our pediatric clinic had a different vaccine form that they were using, and the clinic changed it right then. They got the other form in use that day. And they also recommend a clinic specific peer review process. So we'll be getting that report and working on that. The clinics just did a great job. It was great. Do you have anything you want to?
No, I think you covered everything.
So it was a good process. That they do that as part of their services to us. So that education and the risk assessment, that's included as part of our coverage and their services as our medical malpractice carrier. So I thought it went really well. And as I was walking them out the door Thursday morning, I noticed someone standing with Mandy Weed with a briefcase and a badge. And I thought, I wonder who that is. And so I chased after Mandy, and we did have a DOH investigator show up related to a family complaint that was from August of 2024. That's
22.
or 2022. Sorry, I wrote the wrong thing down. Because so did she actually. And but which is a little interesting because we did have complaints. Depending on the severity of the complaint, they are investigated immediately, or they are often deferred to your survey, which you probably recall we had in November. So it's kind of interesting that this complaint was from 2022, didn't rise to the level of being investigated immediately, but also wasn't covered on our survey. So they exited on this Tuesday, after DN showed up. So we don't have the final report from them. We believe there's probably some opportunities around urinary catheter, perineal care, and documentation and care plans. If there are findings, we will have to submit a plan of correction, really similar to the survey process. Is there anything else you want to add about that, Julie, or?
So, hence, no report from our chief quality officer in writing. She was
Yes.
a little bit busy for the last
That-
couple of weeks, and it really was. The investigator left as DNB was coming in, the educators were walking out the doors, the investigator was coming in, it was like just snowballed, and we had a DNB here on educating for 3 days.
Oh, I forgot about that. too.
Facility directors were here getting CHOP training, which is their hospital facility training. So
Yes.
it was a whirlwind of a couple of weeks.
Yes, so I just, DNV was wonderful, I felt like, and I heard that from several other staff. Just, I think it's worth choosing them to be our accrediting body. I think there's a lot of value there. Their approach is very different from the Department of Health. They exited yesterday and they gave us several, they call it, was it noteworthy? Oh, no.
Noteworthy efforts.
Noteworthy efforts and NWEs. So.
Noteworthy efforts are good.
Yes,
Yeah.
there's.
Opportunities are
this is-
bad. I just want to make sure. All right, good.
Noteworthy opportunities. Well, opportunities for improvement.
Opportunities for improvement.
OFIs are things that you should probably look at, but it doesn't rise to the level of a non-conformity.
Okay.
So, and again, we don't know, we don't have a report yet. They have 10 business days to get their report to us. But the noteworthy efforts, there were a lot this time and, so I'd like to share those. So one, they thought, one of our patient grievance letters was, she said, this is the best I've ever seen. And the process we have, for communicating with patients who have complaints, was really great. The expansion project, just overall, but also what we're doing with this sterile processing department, what materials management, just having the foresight to include them in that work. They were really impressed with that, and just sterile processing overall. They've had no immediate use team sterilization in the last 6 months, which is really great, and participated with Olympus, who they are manufacturers of the scopes. They participated in a project and ended up having data in an Olympus bulletin. Really great improvement work there. They were super impressed with the Blue Band, 4th trimester, our CNA apprenticeship program, that we have crisis managers in the AD, that we have 24/7 pharmacy, that we have a retail pharmacy, that we have a pharmacy tech program. The resources we have for medical staff services. So they're talking about MD staff and MD stat, which is the software we're still working on, but to put peer review in an electronic format. And then someone in place prior to Ron retiring. I thought that was really great that they could have that handoff and that knowledge sharing. So the other good news is they do survey to your previous nonconformities. So what they saw in the survey last year, and if they see objective evidence that we've completely corrected the problem, they close those. And so they closed all of our previous nonconformities. So that was really great. And they did find some, there were opportunities for improvement that they shared with us as they went. But there probably will be, the number may change, and they want to remind us the number doesn't really matter. It's, what you do with the findings or nonconformities. But they said there were 8. That may change as they combine or separate those. But some of the areas that we will have to create a corrective action plan for and submit that after we get our report. We're about contract review. So we've done a really great job with our contracts that affect patient care, direct patient care, but making sure that we clearly outline and cover the rest of our contracts and review them. Just some annual training, especially for folks that are contracted, and including those in that annual training, or some small components of annual training. For example, antimicrobial stewardship training for our providers has to be competency-based. And that was a piece we just didn't quite pick up on. So some small things there. There's that area outside of the cafe, the little, what is that called? The courtyard outside of the cafe. We need exits and fire alarms, auditory and visual alarms out there. And that's just probably been grandfathered in for a long time, and we didn't. So that's a great catch, that we'll implement that. A few things with like, food storage, and some opened, like, okay, the EKG leads, which I don't know why they put the number in that they do, but it's never the amount that you need. It's more than that, and then nobody wants to throw them away. So, but we didn't have any expired meds. We didn't have any expired supplies. So that will be one. There's a piece of documentation with restraints that we just had a different interpretation of what that meant. So it has to do with the provider assessment of the patient and how that's documented for those in restraints. The goals, when we have a drip, a medication drip, making sure that the physician has outlined what the goal is that we're trying to get to with that titration of that drip. Some documentation related to anesthesia post-operatively and our H&P documentation. And I think there was one other thing related to the trash compactor and just how we operate that I think it's just something we've all walked past as long as it's been here. And so it was great to have fresh eyes to see something and go, why are you doing that? Oh my gosh, why are we doing it? And just something really simple to.
And I have to say, what I love, after we had our report out, which all of the directors were invited to, literally by this morning, I had emails from 2 of the areas with their plan and all the communication and the corrections already started. Yeah, they were IMing like yesterday. I was like, wait a minute, just give me a day.
Calm down.
So that just shows, that the team took what they said to heart and they're already working on the fixes.
Couple of things I wanted to mention, and on the noteworthy efforts, what I really appreciated about those is so many of them were places where we've reached out to fill a gap in the community. The Blue Band Initiative, the 4th trimester, the 24-hour pharmacy, because without our 24-hour pharmacy, there are no pharmacies available. So it really reflects that vision of being out in the community and looking for gaps and stepping into them. So kudos. And again, Dave in Central Sterile Processing always shines, as does Nasser. So it was really good to see all of that. The other thing, last time they were here, you might recall there was some confusion about how we align board's oversight of quality. And we wrestled with what are they really asking us to do, and kind of redesigned the quality process and the way reporting is done to quality. And evidently we got it right, because she liked the story. She appreciated the oversight that quality is providing. And I feel like there's much more clarity there.
Well, and I wanted to say, one of the things that was different from previous surveys that I've been in is they did the quality management system, which is basically in ISO terms, how you run your business. And they did that first, and they were talking about strategy, and Julie came in and spoke about how we do strategy and how that's tied to the QAPIs and the quality process. And anyway, I really appreciated how Julie spoke about the work that you do along with us to keep that at the forefront. And I think they were impressed. It felt like, yes, we're on the right track. Yeah, we're really getting there. So yeah.
Can you remind me again how we on the board get the results of the survey? Forget.
I don't think.
Is it just reported back at the next?
Yeah,
meeting?
it's been an agenda item on both QI Council and here. We've tried to make sure that at QI Council, if there's like accountability that needs to happen for certain items, that it goes there.
All right.
There's no reason you can't see the report. I don't think you want to. It's 50 pages long. It's a very long report, and all of our corrective action plan goes into it. But
So if anyone wants to see it, they can. Otherwise, the next meeting will be yours.
yeah, we summarize it.
All right.
So they have 10 business days to get us the report. We have 10 calendar days to get a corrective action to them. And then 60 days, I think, to make sure everything is is complete in our corrective action.
Mhm.
So those are the milestones that you hear about, that we've submitted the corrective action. It's been accepted by the DOH and last time it was DOH and CMS and it went
Right.
back.
Yeah.
So, and then the, it's been accepted and is considered complete would be what you'd be listening.
There's, I mean, we won't know for sure until they, give us the final report, but there were no items that they will have to come back and resurvey for, which is good. So, yeah. Feel like
Any
it was
questions
very successful. survey.
about those particular items? All right, how about is there anything you want to call our attention? Well, thanks for all the work that you and your department did on that.
A ton of people, but it's not just me at all. I mean, Dee Dee is with and Ron and Trent and Wayne got to go along with them the whole time and tons of staff, are being interviewed or talking about their work or showing documentation, providing policies. I mean, it really takes everyone and it's kind of a fun experience to me as an employee to get to work with all these people that are smart and hardworking and to kind of show off what they do. So.
All right, well, thank you in proportion to whatever you did then.
You're welcome.
So, yeah, thanks for doing that. So what about, is there anything you want to call our attention to on the dashboard? I assume everybody's had a chance to review the dashboard. Is there anything you want to call our attention to before we open it up to questions that we might have about it?
On the ambulatory services side, the fall risk screening for FMCE, FME, and internal and adult medicine is just doing amazing. They're doing great. I do want to call out that the staff meetings they've been having in the clinics, they go through these measures. They've been going through, they go through patient satisfaction data and comments. They talk about improvements that have come out of incident reporting and patient grievances. So I feel like that was a piece of what they saw in the risk assessment too, is that's really making a difference to have those all staff meetings and how valuable it is to the employees. I don't think there's anything else there. The patient satisfaction data was in it again.
Are there any questions that any of the board members have about the dashboard?
Looking at just the trends on the diabetic foot checks, and I'm wondering if family medicine Cleveland has something to teach us about their trend and how they consistently stay above goal.
I think they do. I don't know if you want to talk about CC or Dr. Martin.
They've definitely shared their tips and tricks, and what we've got now is little magnets of bare feet. So if diabetic foot checks are needed, we put them on the door frame or the magnetic
That's
board
clever.
outside as a reminder of, hey, to check their feet. It's making it visual, makes a difference.
And I think Dr. Thomas has indicated how important it is to his teams as well as the rest of the providers. Like they prioritize that and make sure their team knows they care about it.
And patients, they've come to understand why their feet are being checked. Do they puzzle over that at all, or
I don't think they necessarily puzzle. Some don't like taking off their shoes and socks.
Gotcha.
So if we miss it, they don't mind.
So they may not remind us.
So
Right.
they may not remind us that it needs to be done.
Got it. Okay.
I do want to talk about, Julie brought up, there is so much here and there's so much work that's done to ensure that this care is happening, that we're keeping track of it, we're measuring it. And I think there is probably an opportunity to spend some more time on measures. And so I don't know if you want to.
Yeah, this is what I emailed you guys about. That the idea is that we would take we would select a measure that is of interest, particular interest to each of us individually. We would come to Mandy with that, and then in future meetings, there would be a sort of a focus, kind of a deep dive on one of the measures, and I sort of, just to take the lead on it, I asked Mandy to talk a little more, maybe at the next meeting, about the patient restraints, how that's measured, and sort of why it sort of kind of ping pongs around. Because I know we do hear some explanation of that, but I'd like to hear a little more about that. So just if you guys wouldn't mind thinking about one of these measures you're particularly interested in hearing more about, then pass it on to me, or directly to Mandy. And then this might involve, well, that will involve her talking more about it, but she may bring in somebody else who's done a lot of work on it to kind of give us more specifics on it. Anyway, I think it's a really good idea. And so think about what you would like her to address. Obviously, if there's more than one, we can do your second one in future meetings. But just to get things teed up, think about one thing that you'd like to hear more about. Okay.
Yeah, I like this idea that helps us to broaden our understanding of the context and
Yep.
educational opportunity here. That's great.
Great. Any other questions for Mandy about the dash? And so, like I said, we're set for next meeting with the patient restraints, but after that, then one of your interests will be covered. So be sure to pass that along to Mandy. Good.
Are we just asking about a particular metric or certain minutia about that?
Yeah, that's the idea. Like you mentioned diabetic foot check. So how, I mean, you might ask, or we might hear about what they're doing up there, so we heard that, or how they determine, whether it's been accomplished or not. And a lot of times that's not only whether they did it, but whether they documented it, when they documented it. So you get a lot of that kind of information, and maybe hear why, what the failures were. Was it a failure to check? Was it a failure to document? How many of the failures, opportunities are a result of documentation or the actual foot check, this sort of thing.
Okay.
So you get some more specifics on the data, how it's collected, and what's required to get a successful instance of it. And also you might hear about committee work on this, who's like on falls, for example. There's a falls committee, right? So what do they talk about there? Who's involved? What sort of things are they working on? What are some of their successes? So you'll hear a lot more about that kind of stuff. Anything else, Mandy, that you want
Well,
to?
just, the questions have come up, like the suicide risk assessment bundle, what is that? And so that would be a good time there is some minutia in there. And so it wouldn't make sense to, dig in deep to everything all the time, but knowing ahead of time, we can make sure we have, like, the measure details. What are all the measures that are in this bundle? And really talk about that, what are the definitions? Because you have that glossary that we've given you before, but it's not as specific as I think sometimes you'd like to know. And if we have a little bit of time, that's not difficult to go into. We just want to be prepared so we're not speaking off the cuff incorrectly.
So as far as being prepared, as I say, we're all set for June because I've put in mine. But if you each wouldn't mind, please, by say the next meeting, by the June meeting, just get her the one that you're interested in hearing about. So then that'll give her at least a month to work on
Exactly.
preparing for the July
Can we
meeting.
just tell her at the next meeting then?
You can tell her at the next meeting or email her. It's up to you.
Yeah.
Whatever you like. Sound good? Everybody else good with that?
Thank you.
All right. Anything else, Mandy, from you?
Unless I'm forgetting something. No.
Anything else that anyone has to ask, Mandy, before we move on? All right, thanks a lot, Mandy. Okay, then we move on to our CEO, Julie Peterson. Julie.
Yeah, I don't really have anything to add except to reiterate it has been it has been a very stressful couple of weeks, and it ended yesterday with D&D's exit on very high note. So, I agree with all the head nodding that went on early. That's a positive process. It's a helpful process. When they walked in the door, Julie Kirkland picked up the phone and said, ADH wants to welcome their D&D surveyors. We're so glad you're here. And it felt genuine. I mean, so we get helpful insights. So there is that. But it was the end of a very long team days. So thank you to everybody who showed people around, dug through documents, made copies, all the interviews that went on. And I don't know if you're aware, there's an elaborate process for HR files, not just patient documents, but HR files, our contract files, policy and procedures. And as if you will recall, we're just off that transition to Lucidoc with all of our policies and contracts. So this was a fire drill around where can we find those policies and the linking documents and things. So a lot of challenges the last couple of weeks.
How many D&D personnel were there?
Great.
They cover a tremendous amount of ground while they're here. That's
Facility,
incredible.
there's a clinical, generally a nurse, there's a generalist, and then there's someone on fire and life safety facilities. So, yeah, and you had your own. But I'm happy to answer any questions.
Did you, you might have spoke, this seems familiar, and I'm hoping that you can remind me the differences for the SNAP program or the safety net assessment program that resolved most of their differences regarding the attestation.
Yeah, so the issue with the safety net assessment program is you cannot go into that with an agreement among all participants that you'll gin it up later and make sure no one loses. So you fund this program through a series of bed taxes. That goes to the state collects it, submits it to the federal government, who doubles it and sends it back. So that's what actually generates the funds for the state. That's why they're in this game. The formula, once that money comes back to the state, how much of that money goes back to hospitals? How much goes into the general fund? There's a lot of arm wrestling in the design of that up front. But then how are the funds that are going to the hospitals distributed back to the hospitals? And what you can't do is have a reconciliation process that says, okay, every hospital, we're going to take the tax you paid in and make sure you got at least that much SNAP money back. The formulas have to operate independently. At one point, the DOH, or the Healthcare Authority, wanted hospitals all to attest that not only were they not involved in such a program, but they were not aware of anyone who was involved in such a program. So they kind of wanted people to rat each other out. And that was there is no program at Washington State Hospital Association. Nobody at the table is designing any kind of backdoor program or back alley program to make people whole. But they weren't going to have CEOs attesting this one another.
Okay. Thank you. That's not what I thought I recalled. So it's very interesting. Yeah.
That, I mean, one of the things that you mentioned here is this, Congresswoman Schreier questioning the United Healthcare CEO. And, that was, it was interesting to get that message basically from her staffer that thanked us for talking to Dr. Schreier about this, when we were in DC. So it was heartening to know that maybe that, we may have had a little bit of a impact putting a bug in her ear about that. Anyway.
The other statistic when we were back there, and if you'll recall, she was here the week before we were back in Washington, DC. And we provided them with pages and pages of information on United Healthcare and on those MA slow pay, no pay practices. But one of the things she said she's repeatedly used is that statistic that we have 1.3 people in revenue cycle for every nurse. that's what these insurance companies are doing to us. So she said she walked around with our paper for a long time and quoted KBH more than once. So it was nice.
Good. Any other questions for Julie? All right, thank you, Julie. And we have our HR staff development report from Amanda.
Yes, so just a couple of notes. So we've been doing a lot of outreach to schools, but also career fairs. So we were actually at Val Homes today for an event as well. And so we've been getting out, and that's something that kind of stopped during COVID. And it's nice to get out there and make personal connections. I got to join my team for a couple of things, which was great. The Perry Tech Career Expo, which was wonderful. We met with hundreds of people actually, and that was great. And then I got to go on a school tour myself with some ancillary services positions. So I had a good time with my team. The hospice volunteer program is going really well. Is also, and Rhonda has helped us with some recruitment in Upper County. So Kyle and Rhonda and the hospice team have really taken this on, I think, to fill that need with the transitions with Hearts and Hands. So that's been going very, very well. And recruitment overall is, knock on wood, but we're steady in a lot of areas that we have not been in the past. We're making some really good progress. And in one of our huddles in my team, we said, are we at a point where we're erasing some of these critical positions where we had a lot of openings in our hot jobs referral program? And that's just a conversation we have not had since we started that program. So we're really excited. There are still some nursing positions, but the CNA apprentice program, I think, has been really great. And Dee Dee can talk more about that. But we're actually in a position where we're saying, what are we going to do if we have excess patient care technicians, which is a really, really wonderful problem to have. So we're very excited about that. Things are going very well. And then I did get an update from our Teamsters contact that there is actually going to be a vote for pharmacy, whether or not they're going to join our bargaining unit, to join our respiratory therapy contract and kind of have a professional technical focus to the contract, or just kind of how they're going to structure that. So you should have an update by then. At the end of June. So our next board meeting, hopefully we'll have a final answer on that. And I have a new business partner starting. Her name's Anna E. And she just hit the ground running with DNV and things going on this week too. But she actually comes to us from Twin City Foods and really has a good lens, just different lens on staffing and labor and attendance. And it's just really great. HR is one of those really unique fields that is in every industry and looks a little different in every industry. So she actually used to partner with our Teamsters rep there. So she's familiar with that and has been getting up to speed quickly. And then, of course, you have heard my news, and that's very sad for me to share. But
I think everyone in
yes,
this room is aware that Amanda's going to be leaving KBH, and it's public as of today. So we kept it pretty quiet.
I know you guys have done well. Good job. But anyway, I'm very sad. It's been a wonderful, wonderful experience. And thank you for your support as I transition to and accepting an offer that was flexible with my family and meeting my personal and family needs. But my last day, I made it intentionally on June 27th so I could say goodbye to you then. So today is not goodbye. So I'll get to work with you in June. So thank you very much.
So should we diffuse over you then from now? Then? Okay, we'll do it then.
Yeah.
Right.
I'm trying to hold back the tears. I know it's
Okay.
anyway, I'm still grieving, so thank you. Yes.
Yeah, we'll okay,
Yeah,
we'll
and
hold off from.
I don't know if I shared with the board that Amanda's going to Greater Health now
Yeah.
to work with human resources and development there. And I happen to be the treasurer of Greater Health now, so I completely lost control of the situation. And this FT was approved, and I didn't realize that they were going to rob out of my backyard. Somehow I feel like I let the team down by creating that position early.
Well, before she joined, it was called Great Health now.
Yeah, now it's.
Anyway, all right, well, I'll save it for you.
I look forward to partnering still with KVH. You won't get rid of me that easy, and hope to in that new role be able to do some things with you. So good. Thank you.
Any questions for Amanda? All right, thank you, Amanda.
Thank you.
Next up, we have our expansion project update from Ron.
Right. Report starts on page 22. I can tell you that we're still targeting June 12th for occupancy in phase 1 area. Things are looking good for that. We're working on finalizing the phasing plan for moving forward into phase 2, 3, and 4. Kind of shuffling some things around, trying to create the best workflow for KBH, the lowest risk for infection control, and the best constructability. So kind of shuffling that around. I think we've got a good plan now. I think it'll probably pull 2 or 3 days off of this. So just finalizing that. As far as planned outages, we did do the XL4 and the Mezzel panels, and there was no incidents there, so that went well. There's really only one shutdown left, and that's panel NH3. But that'll be a couple months down the road. And unintended incidents, we did have a leak in the new RODI water piping system, and that surfaced in materials management. It leaked on the floor. It wasn't, it was just a drip, but there was a fair amount accumulated over time, but no products were lost, so that was good. And that's since been repaired. And I can tell you next week, we will be finalizing, we're doing trim and test on the fire alarm system, the nurse call system, and access control. And that will pretty much button up all the systems for you. Yeah. So outside of that, you'll get a chance to see it next Tuesday, and it's looking good. Most of the ceiling grid is up, and so they're in the process of dropping tiles now. Finishing up the flooring everywhere. That'll be done tomorrow. And MRI magnet gets ramped up tomorrow. So yeah, things are moving along.
Wasn't trying to rush you, Ron. I just thought you wanted to be ready, so.
Oh, no worries.
Ready for pictures.
You don't like thick shag carpet in the OR?
In the OR, we do have it there.
Oh, okay.
Is this the?
That is back in what's gonna be clean surgery, clean storage. And so that's the CT control room there. Get in on the CT. And that is in a housekeeping closet, and that's the humidifier that will serve CT.
So on Tuesday, we're gonna get up close and personal.
You are, yeah. That's in the MRI and CT mechanical room. That's already looks quite a bit different because they've got all the MRI equipment that came in on the 20th in there and connected up. So yeah, that is. Oh, that's an outpatient surgery, the new outpatient surgery. That casework there will be the nurse's station. So yeah, it's all floored and gridded.
They'll put some ceiling tiles in.
Eventually, yeah. They got to get cover inspection first from the city and the state, and then they drop the tiles. I think they're just waiting on that in that area. And that is just another shot of that.
Ron, what will be the status of the MRI magnet when you do the tour?
It'll be ramped up. All goes well, so.
So don't take anything metal in.
The door will be
But
closed.
there is a window in the control room. You'll be able to look into it. You'll be able to go into the fun part, the mechanical rooms.
In the tunnel.
In the tunnel. So yeah, that's back in what's gonna be the OR equipment room. But that's now being temporarily used for materials management until they remodel their existing area and break out that wall. That's all complete back there, in there. And this is up in the radiology penthouse. That's the old exhaust fans and return air fan that are now demoed, and that's system air handler in there is also demoed out and tied into the new air handler floor. And that all went really smooth. And yeah, so that's the new ductwork that connects up air handler floor to where those return fans were. And then back off to the left of that is just where the air handler was and the new ductwork there. And then that's the stormwater system. They finally got all the pieces and parts for that. That's kind of what was holding up our parking lot. But they've got that in and now they've got it backfilled and compacted and getting ready to start grading the parking lot. So
What am I looking at here?
it's basically the black pipes that you see there are what carry the water into those yellow diffusers, and it basically just spreads the water out in the ground
Okay.
so that you get a lot of surface area for the stormwater to go down in. And it kind of starts at one end. It's actually at a little bit of an incline, and it'll start at one end and start filling up that way.
What goes on top of the yellow stuff when you're done?
Gravel, there's a gravel bed under it and a gravel bed over it, and then I think that is in the vascular room. Yeah. Some of the new casework. Pretty much all done now. That was one of the electrical shutdowns we were doing at night, getting all those tied in.
I think that's the end. So,
All right. Well, we're looking forward to Tuesday. Be great.
How are things going with Walker Construction?
Good. Yeah, it's collaborative. We meet every morning and then we have construction meetings on Wednesday and just trying to get everything coordinated. There's lots of moving parts, trying to get the trades in there. And when you're doing flooring, it's kind of, they want to push everybody out. And so it's kind of interesting, but yeah. So,
Any other questions for Ron? All right, thanks, Ron. Welcome again, Wayne. Thanks for coming. All right, anything else for Julie, our CEO, before we move on to operations? All right. So on to operations, we start with our Chief Nursing Officer, Dee Dee.
So just a couple of things I'd like to call out on my report, which I'll probably be talking about for the next few months, is our dialysis program. We are moving ahead. It's getting closer and closer. We had a team of our staff that went and visited Holy Family in Spokane that uses the Tableau machine. And they were able to do a lot of collaborative work. They came back with, just some of those things that you just can't learn in a quick Zoom meeting. We're getting ready to put together, or we're working on putting together what we're gonna lovingly call a kidney committee. Very similar to our trauma committee, our cardiac and stroke committee. So we did have a great, I think, meeting today, a nice collaboration that Dr. Martin put together with our two nephrologists. And we happen to have Dr. Owens here and Dr. Schmelzer both on site. They were able to come up along with Cody and Jeff. Wayne, our coordinator, and Trisha was able to help facilitate that meeting and just begin talking about, what is it going to look like when a patient comes in? And we know we still have a lot of work to do, but policies are getting put together. They will be going to this committee once we get it in place, which we're going to be meeting Tuesday to kind of discuss further details, get some dates. So yeah, 2 staff members are going for education and we're looking at an early July start date.
And while I appreciate the call out and full disclosure, me pulling the meeting together means Trish pulled the meeting together.
And then of course there's Andy who makes sure we're all here.
I mean, we're not gonna do it as a primary. This will be a patient's here for something else, but needs it, so rather than have to ship them out, we can provide this
Yes,
service.
this is that inpatient. We still have our two ICU rooms being finished with some infrastructure changes. And we still have all the right people involved in, we are doing weekly meetings, just quick 30-minute check-ins that include, infection control. We're talking closely with Ron. And Wayne, who still does not have an office, he will hopefully once we get the phase one moves. He's been working up on the mezzanine, and I think he's the first one who claimed one of the little file cabinets. But he's doing quite a lot of work, and we're really starting to talk about getting the staff engaged a little more. We do have our two nurses, but really working with the ICU team and anybody who's going to work back in that area as a whole. Because yes, you're going to have that patient for the dialysis, but we still are taking care of the patient, fully. I think Dr. Owens is a great champion on the inpatient side. He has some experience, working with this in rural facilities. And I know he'll be working with the hospitalist group. And of course, Dr. Schmelzer and our ED group, they're familiar with the care of these patients from Yakima. So it's very exciting. The other thing, just to call, I'm sorry, the rooms.
Yeah.
Oh, we get our rooms back?
Yep.
Yay. Very good, very good. I also do just want to call out, there's been a lot of great work recently around our point of care ultrasound work that we're doing down in the emergency department that will be branching out, of course, organizational wide, with family birth, our clinics. So a lot of work with protocols. I think we're going to talk about it a little during Dr. Hoppy's report, to just looking at equipment and making sure that we have all of our systems in place, from documentation and coding and revenue. And just lastly, I just have to keep talking about this NAC program because, we still have our 6 candidates. 4 of them have already actually applied for open positions. And yeah, I'm afraid we are going to probably get to a point where we won't have the spaces. But I do realize that position does have some turnover. And Amy's been doing a phenomenal job with the students, and just seeing, I'll be curious after this first class is done, what we can do maybe to improve next ones, or maybe we're doing everything right this one.
But I already have the cohorts for.
Yeah, and she's already working on her 10. We want to have one more class in July that be finished before Labor Day weekend. And then, this isn't going to be a continuous, we're thinking, 4 a year, but we'd like to get another one done this summer.
I mean, one of the things I love about that is, not only that we can develop a lot of people are already here, happens sometimes, but also rather than just go try to recruit people for positions, we're going to make them. That's really being proactive about it.
And it's, the thing, I think probably one of my favorite parts about my job is to really watch when somebody goes through those stair steps. And you know that the students that we're taking care of right now, that some of them, this is their first, big job. And a first job in healthcare, where are they going to be a few years from now? 5, 10, 15. So hopefully we can just keep, opening opportunities.
And we do have our tuition reimbursement program
Yes,
now for if they want
nursing.
to become an RN. So actually the goal is we want that turnover so that we can keep growing them and keeping them here. So that's great.
Akin to just the birthplace. Look at the technician who is now RN, who's back in birthplace. I think I probably know who that is, but I'm not naming names, but that's just really exciting to see somebody
Oh, yeah.
go away to school and then come back.
Yep.
It's really neat seeing people grow.
Yeah, you can see Cody called out in the ED. We have a patient care type that we, I hired her with no experience right out of school, and she is going to be sitting for her NCLEX in a couple of weeks. Very cool. We have another one who she's, I think, tomorrow taking hers. She's going to be coming into family birthplace. So we're actually bringing these new grads, into, I'd like to say a little more specialized area. Usually it's med surge, beginning, but we're really working on how can we make sure that they're gonna be successful and work in an area that they both, they have experience in and they're wanting to work there.
Mhm. Yeah, they have an affinity for that niche and just
Mhm.
keep growing in it. That's really neat.
Any other questions for Dee Dee?
I had a question on the emergency department section on page 29. The first bullet point, volumes are down just slightly, but then it says, however, the portion of those admitted or transferred was up significantly. 14.8 versus 7.9. Is that a good
That's
thing
a
or a bad thing?
No, I would say we're, for one, our transfer rate was actually really low. I forget what I told you last month. It was like 4
Yeah.
something percent where we were averaging
And
6%.
when we say transfer, because we can't provide the service, we have to send
Sometimes
them.
or we don't have the beds because we're full.
Okay.
So your
Our
choices
expenses-
are admit, discharge, home, or transfer.
Mhm.
And our transfer rate has been, so we're admitting or discharging home 95, 96% of the patients, which is a significant improvement over the number of transfers. And if you don't believe me, ask EMS in this
Yeah.
county. The number of patients that we're able.
And also we are, our mental health patients.
Yeah.
Our behavioral health patients do fall into this and, we're still seeing a significant number of those.
So can you just, again, the transfers move up 14.8 is, that's a lot higher than the 4 or 5%. What is it I'm being told with this statement?
Well, it's admitted or transferred. So we are admitting, it's both. They are combined.
Okay. It seems like two opposite things, so it's weird they're combined into a statistic, other than being released to go home is the only other option.
Does that
So-
just speak to the acuity that they need this care versus being able to be
Absolutely.
discharged?
Yes.
So it's not supposed to, I get what you're saying, John. So it could be like 2% transferred and
Because since it's blended, you don't know
12.8% admitted.
what is it being told?
Yeah,
And I
that
can-
information.
I can definitely give you those numbers broken out.
But I think-
trends for both.
Yeah. The significance of that is these are patients who need hospital care.
Okay.
They're not done being treated
Right.
one way or another.
Here or somewhere else, they need care in a hospital.
So is that
So like-
indicating the acuity is up then?
Yeah, that's, like Erica said.
Yeah, okay.
Yep.
That's great. Thank you.
That's a good question. Any other questions for Dee Dee? All right, thank you, Dee Dee. All right, next up, we have Rhonda Holden, our Chief Ancillary Officer. Rhonda, can you hear us?
Yes, hi everyone. My report is on page 31 and 32, and I would say I hope all those students go on to become ultrasound technicians because we really need. I really don't have anything to add, but I'm happy to answer any questions.
I was going to ask about the chemistry analyzer. It says the new arrival date's projected to be May 15th, which has come and gone. Did it happen?
No, now I'm hearing it's the first week of June, and that's a
Okay.
manufacturer delay.
I just, in the ancillary services area, in the coming months, Stacy Alea has Kenny from Diagnostic Imaging, Katie from the lab, Marcus from rehab, and Nasser from pharmacy, who will all be going to her all staff meetings to talk about all the new services we've added and talk to the providers who are making referrals about how we can earn more of their business, make sure that we're providing all the care we possibly can locally. So most of the ancillary directors will be parading through the clinic all staff meetings in a couple of months.
We're also asking to be included to new providers orientation for those ancillary directors to be able to spend time with them so that they can get to know what services we have here. I know Marcus really would like for them to come and tour our PT and OT speech building so that they can actually see what we have there.
We can make that happen.
So about imaging, what you're talking about. So, how often does it happen where someone needs an ultrasound at 3 o'clock in the morning? And if they do, what do? We send them away?
It hasn't honestly happen very frequently. I think the burden is just the burden of being on call. And most of those studies that we have done have been negative studies. So we would either be faced with having to transfer, which it's likely that most hospitals wouldn't accept that patient as a transfer just because they probably don't have ultrasound either. And we just kind of got in this situation through the EMTALA requirements.
Yeah.
The other option would be to keep the patient down in the ED until they came on at 6 o'clock in the morning. Or if they had to, for space, put them over on the med surg unit for observation, which that's probably not real likely either. We'll be bringing forward some requests for staffing to see if we can get anyone that will be willing to work on the weekends. Potentially people that might want to work a 3 to 11 shift. And if we could get a traveler doing a Sunday only, that wouldn't be maybe too cost prohibitive, but it's very difficult to find ultrasound techs right now. I know Amanda and I have been working with a company that was supposed to be recruiting someone for us that we could hire for a permanent position. And I believe they sent out our information to 3,000 different ultrasound techs, and we didn't get a single bite on that.
Okay. Any other questions for Rhonda? Thanks a lot, Rhonda.
Thank you.
All right, next up, then we have Stacy Olea, our Chief of Clinic Operations. Stacy.
My report starts on page 33. I want to talk a little bit about the medical assistance apprenticeship positions. We've already had to close that posting because we have 22 applicants in about a week and a half. It's an amazing program. Where we sit right now, we've got about 7 apprentices who by the end of this year should be moving into certified MAs. But we also have about 8 providers who are probably coming this year, and we have about 7 more MAs who will be either going to nursing school, applying to nursing school, applying to PA school. So just like what Dee Dee's hoping, we see that process all the way through the MA program. So they stay for a while and then go on. A lot of them still work for us per diem as they work on their nursing degree with the goal of coming back to KBH as a nurse. So it is a really great program to have here. And then just a little bit about access and appointments. Kat's been doing a great job at bringing providers in for interviews, and we've done a great job of being able to recruit providers. We've got 2 PAs starting in orthopedics in July. That's going to give us, they want to be busy. That's going to give us about 120 to 150 appointments a week, more than what we have now. They want to see 20 to 25 people a day, 3 days a week. So we'll have always 2 people in orthopedics, 2 providers in orthopedics, Monday through Friday. Plus, we're going to reopen our Cleellum clinic once a week up there. So we're thrilled to have more providers up there.
We need more orthopedic patients.
We need more orthopedic patients now. The other thing, we do have Dr. Henry. He is a locum OBGYN. So we've started taking back our GYN patients. He's also doing surgeries here, so we'll be able to see some volume and take care of those patients in our hospital system. We've got Dr. Williams, who's also a locum, who is doing 2 to 4 days a month in the clinic for OBGYN coverage. And I believe OBHG, we've got another provider confirmed to be starting in July, OBGYN, who will really help us be able to expand those GYN services. Internal and adult medicine.
HG.
OBHG.
Yeah, what's HG?
OB hospital.
Oh, okay.
We've got internal and adult medicine. We've got 2 more providers who are going to be starting here soon, more interviews coming. And family medicine, we have another mid-level coming in there, I think next month, and we're still doing more interviews. So things are starting to look up for the clinics.
And the teams are really developing it. It's been really fun to watch Dr. Beard just really embraced this model. Vanessa Wright, I think, is building her team there. And really, that model that was done almost 2 years ago that provides the physician with more time for oversight and time to guide the APCs, huddle in the morning, figure out what's coming, and really open up access. But both Dr. Bearden and Dr. Wright have really stepped into those roles. So, and Dr. Woodard, who's only been here 6 months, or,
January.
I think is slated to pick up 3 APCs into his partner group.
And we've got a physician starting in family medicine, Cleella, and we're interviewing for an APC up there too. Very exciting.
I don't have to get my report.
I know, I still. So any questions?
Questions? Stacy, on it?
No, I was just looking to see if somebody.
I was just gonna, with orthopedics, for example, ramping up the number of slots we have for people to see. I always kind of envision orthopedics as primary lead you into a surgery or something. Is there a lot of orthopedics that are not surgery related to?
There's a good portion that are, but we'll also be able to, right now, Dr. Longo had to step back and do surgery only 2 days a
Yeah.
week and 2 days in clinic. He'll go back to doing surgery 3 days a week.
Oh.
So those are your joints, but there's a lot of stuff the PAs can do without having to do surgery. Plus, then they feed into Dr. Longo's surgery schedule too.
And some of the stuff that doesn't go to the operating room, still procedural injections.
Done in clinic.
Yeah. So. It's work by a surgeon.
Right direction. It's nice to hear.
Other questions? All right, thank you, Stacy. Next up, we have medical staff. Start with our chief of staff, Dr. Hoppy. Dr. Hoppy?
Good evening. Thank you very much. I have 2 things for the board this evening, seeking approval of. My report is on 36 and 37. Page 36. We have 3 initial appointments and 5 reappointments. The Medical Executive Committee reviewed these this month. We would seek your approval for these credential files.
Has everyone had a chance to review them online? Yeah. Okay. All right, Dr. Hoppy, go ahead.
Yep, and then secondarily, under the discretion of Dr. Schmelzer, the Medical Executive Committee reviewed the delineation of privileges for the point of care ultrasound privileges. And you all have that on page 37. And basically, we loosened up the criteria for initial credentialing and renewal credentialing for those privileges, just to reflect more realistic volumes. And so I'm happy to answer any questions regarding the delineation of privileges for the point of care ultrasound privileges.
Let's start with the credentialing. Are there any questions or any comments before we move to approve the recommendations for appointments and reappointment? Do I have a motion then to approve the list of appointments and reappointments?
I approve.
Okay, we have a motion from Terry.
I approve the motion.
Good. Second from
Second.
Erica. Okay, there's no further conversation about the list. All those in favor of approving this list of initial appointments and reappointments, please say aye.
Aye.
Okay, thank you. Then we move on to the delineation of privileges regarding point of care ultrasound. Are there any questions or anything for Dr. Hoppy about why this changed? As she said, it's about sort of more realistic expectations about what we can, what people can do. I know you guys discussed this in NBC. You guys have any questions for Dr. Hoppy about this?
No.
All right, then do I have a motion to approve this revised delineation of privileges?
I'll move.
Okay, motion from John,
I'll second.
second from Erica. There's no further discussion. All those in favor of approving the amended delineation of privileges for point of care ultrasound, please say aye.
Aye.
All right, you got it, Dr. Hoppy. Anything else you have for us?
No, just one last thing. As you know, Dr. Hibbs will be, resigning, from his position of Department Chair of Medicine. And so we will likely seek an interim department chair, in the next, month or two. So stay tuned for more information. So thank you.
All right, thank you very much, Dr. Hoppy. Moving on then, we have our Chief Medical Officer, Dr. Mark. Go ahead.
So thank Dee Dee for giving my report on dialysis, Stacy for giving my report on staffing. John caught one thing that I omitted under APCs on, my report starts on 38. At the top of 39, I show that we are still posting for APCs. We are not trying to staff up to 5 APCs in that clinic. Those positions are filled.
For orthopedics.
Yes. And really, with that, I think all I have to add is appreciation to Dr. Hibbs for his service and his counsel. I think we made a pretty good team. And we wish him well.
Yeah.
I'll take any questions.
Questions for Dr. Martin about CMO report?
Actually, I do want to call out one other thing.
Okay.
At the bottom of recruiting, I included the work that had gone on in April to get these people here. And it's work that's largely invisible, but there's a tremendous amount of time working with recruiters, working with agencies, getting applicants, screening them. We probably interview 1 in 5 candidates that are presented. And by the time they get to the interview process, they're pretty well vetted. It's pretty rare that we bring somebody for an interview feel we can use. It has happened a couple times this month. We're not just taking anybody, but there's a tremendous amount of work that goes on before those names get to us, before they get to Stacy's clinics. So Caprunner does a lot of work, and it's reflected in what you're seeing in recruiting. I think that we've probably hired as many providers so far this year as we did all of last year. I'll check that. I think it's getting close.
What we've discovered is there's a lot of demand out there.
I would just like to share that, having received Dr. Hibbs' resignation, Dr. Martin and I sat down and we've made the decision to not fill that position for now. I think we're all aware of the financial position we're in. Dr. Martin, at the time we created the medical director of clinics, was half-time as chief medical officer. He's full-time now, so he is looking ahead at dividing his time between clinics and those.
And what we think that'll look like is my mornings will be spent in Stacy Hill, and my afternoons will be spent up here.
Okay. Any other questions for Dr. Martin? Thank you very much, Dr. Martin.
Something to be said for going late to the agenda.
All right. Next up, we have our Chief Financial Officer, Jason Adler. Jason.
Thank you. My report's on page 40. It starts on page 40. It goes on for a while. Some highlights for the month of April. Ambulatory clinic visits still below budget. However, happy to report, digging into the analytics and numbers, I am short a few visits. So the on-call provider, we determined I wasn't including in these stats. So I'll have some more visits to include going forward. That started in January, so we'll correct the year to date as well. There's about 200 to 250 visits a month there that we were missing. April had really strong volumes in surgery and GI. GI was very high compared to prior months, with 195 scopes compared to 161 budget. So we had a really busy month there. Overall expenses were over budget, primarily in salaries, temp labor, and purchase services. For the month, revenue was 21.4 million, which is a record for KVH for total charges. So April is the highest we've ever had in total charges for the month. Though still having that, we still ended the month with an operating loss of 160,000, That was due to, again, expenses being over budget, but also the third part of the leg with healthcare is just reimbursement on those charges. So we kind of have all three going on the first quarter, with revenue being low, payer compliance issues, and then expenses. So a loss of 160,000, but a much lower loss than the last 6 months. So hopefully we continue in this direction. Revenue cycle team made a lot of progress in April to mitigate the impacts of Optum, and most everything is back to digital or electronic workflows. They pulled AR reported from 85.8 days in March down to 74.8 days in April. So a lot of progress there on the AR. In that time, some of the cash flow is still coming in once we started getting claims out, but the cyber attack, kind of a second phase of bandages, was posting that cash back to patient accounts. So AR was artificially high reported last month. We're receiving cash, we just couldn't repost it back to patient accounts. So we're able to post all that back to accounts. That's what attributed to AR being way down, but cash still fell because we were getting some of that cash prior months as well. And there's still just a lot of spending going on with the expansion project. So total cash, as expected, throughout the year to decrease with that significant capital investment. Any other questions for the financial summary?
Any questions about the summary before we get to the specifics?
So just the numbers, stats on page 44. See, the admissions and patient days were still below budget, but stronger than prior, and average length of stay is right at 4.0 days, which that's the limit that we can go up to by the end of the year. We want to be below that 4 days length of stay. So we're sitting at 3.9 now for the year. But I want to just highlight surgery procedures. We're well exceeded budget for the month, and the GI procedures there on rows 11, 12, and 13. And then at the very bottom, I like to note the clinic visits below budget at 3.6% compared to year-to-date of 6.5% below budget. So even though those numbers are lower than actual, it is consistent and showing that we have increased access there.
Are you saying this is one of the lines that's going to get corrected?
Yeah. And any other questions on the stats?
Questions?
Turn over to the income statement on page 47. So total charges, 21.4 million. That's the record for KVH ever. Still below budget by 800,000 on charges. So that is what attributes to that. Still coming in at a loss position of 160,000. A little bit different for the month of April. Our investment income or loss, it's an unrealized loss, brought the operating margin or operating income down further by 44,000. So April wasn't a great month for investments, but they are unrealized investments, so that will come back up by the time those mature. That is all I have on April. Do you have any questions?
In the dashboard, did you always break out Medicare Advantage, or is that new this month?
That was new last month.
Last month, okay.
Yep, sorry, I didn't highlight that.
No, that's all right. It's
Yeah, it used to be a pretty minimal portion of our total payer mix, but Medicare Advantage, as you can see represented there, has increased 3 times since 2021. So we're in about 4.5%, and now sitting in 2024 at 12.5%. And that's a significant challenge that our revenue cycle teams had working with Medicare Advantage.
yes.
Another disadvantage of Medicare Advantage is that it doesn't settle through the cost report. So like 2023, we just cost settled and we got a 1.3 million positive Medicare Advantage doesn't do that. So it's kind of a double negative for the hospital, and it's not a great service for the community.
That was the subject of much conversation at the AHA meeting.
Yeah, it's an unfortunate product. And it starts with the patients too. We have a constant number of patients that come to us and they can't seek care with us because they didn't realize that we're out of their network, or they're in a very limited network, or even refined to a specific hospital only. So
Yeah, they refer to them as ghost networks, and there's very little attention in the Medicare Advantage world paid to network adequacy. So it's not at all unusual to not have if you need hospital care in Port Angeles, you get to ride a ferry to the nearest hospital that's in network.
Yeah.
So and then, you know, if you get disgruntled about your Medicare Advantage plan, I think that is the first time that a lot of people learn they're not necessarily going to automatically be accepted back into straight Medicare. So you have to apply, and it's based on your medical condition, so.
Yep.
Most Medicare recipients.
If anybody wants to talk to Julie about this after the meeting, I think she could probably.
Buy the first picture.
What is it that draws people to Medicare Advantage?
Like advertising, yeah, sales, it is the new used car market. And
But I would add one thing that it does that regular Medicare doesn't, is it caps or limits your out-of-pocket expense. Regular Medicare has no limit on what you could have to pay out of pocket. For me, that's what when I talk to people, that was their deciding factor. At least I know worst case scenario, not realizing that the service they're gonna get might have a whole bunch of issues. But I think what you do is you get then the Medigap, you know, try to solve that. That's the solution, is you get Medigap instead.
my recommendation is do Medicare plus a Medicare or supplement, you know, to have those caps.
Dr. Barton, you had
Well, just what Jason said, the answer to limiting the expense is a supplemental plan.
Yeah.
And in terms of quality, in terms of choice, that's far superior to any Medicare Advantage plan.
But it just is so confusing. I mean, for people of that demographic too, who are overwhelmed, they're trying to research it and understand it. And like you say, the slick marketing sucks them in.
While talking about payers, it is worth noting, I've been talking with Kaiser about possibly recontracting as well. So we dropped them in 2022. There could be potential eventually. Suggest or request the board of contracting them.
which I think would be welcome in the community and welcome by the PEP, so many folks.
But I know you're trying to put a fence around how this is gonna play out if we move forward with them, so.
Yep.
Because obviously there's a reason we dropped them before.
any other questions for Jason? Anything else before we move on, Jason? All right, thank you very much. Next up, then we have our community relations report with Michelle Worrell, our Chief Public Relations Officer. Michelle.
Hey, good morning, everybody. Other than, so you have my report. Looking at those other projects, that's, you know, they're little bullets there, but they're actually taking up a huge amount of time right now. And as you can see, we're gearing up on lots of events going on throughout the week and the weekends. Alicia will be reaching out to you tomorrow to see if anyone is interested in helping out with Senior Health Fitness Day on Wednesday. I know John and Terry participated last year, and so just a heads up, if you have any interest, she will be reaching out tomorrow. In addition to the report, I wanted to give you a heads up on the analytics that you're used to seeing on the website on on a quarterly basis. Not too long ago, HHS put out a ruling regarding HIPAA compliance and collecting data on websites. And at that time, it basically, a lot of people thought it was overarching and didn't really know the interpretation. but there was feeling that collecting any type of analytical information from the website might be a violation of HIPAA. In March, well, I would say in late 2023, the AHA joined the state of Texas and filed a lawsuit against HHS on this issue. Basically, I'm not going to pretend to be a legal expert, but it's an unclear statute or it's an unclear regulation, and it's extremely overarching. They're making organizations determine intent. In March of this year, HHS put out a clarification statement, and basically the way to summarize it is, if someone comes to our website and is looking up a service just to learn about the service in general and whether or not we have it, it doesn't matter if we collect their IP address, which is kind of what's in question here. And that's what happens through Google Analytics. If someone comes to our website and is looking for the address of the clinic because they have an appointment, we are now violating PHI because it could indicate that they have an intent to receive services at that location for a condition that no one needs to know about. Hopefully you see the problem with that, and that intent in looking at websites is not something we can do. We're also seeing that this is becoming, I'm sorry?
Nope.
Okay.
I didn't say anything. It's okay.
All right. This is also becoming a very easy target for attorneys that want to make a quick dollar in submitting claims against hospitals that are collecting this information and claiming HIPAA violations and doing out-of-court settlements. This has really come to the forefront. I talked to Julie earlier this week, and both of us decided this was not a risk that we could take. So we have turned off all Google Analytics, and we are starting the process to see what other options are out there. There's a lot of valuable information we get as far as website traffic and where people are having issues and what they're needing, but none of that is obviously worth a HIPAA violation. So if and until we can figure out a solution, those analytics on website traffic are completely gone. Other than that, I will take any questions.
Questions for Michelle?
The experience healthcare event in July, what age group or grade level are you targeting for that?
Juniors going into their senior year.
So they should be people going into their senior year. Okay, terrific. Thank you.
No problem.
And I'm Kyle's putting together a panel on community needs of the community as it relates to the healthcare workforce that I'm going to be on.
I think I'm going to be on.
FYI, so there will be board representation there. Any other questions for Michelle? All right, thank you, Michelle.
Just a heads up, as soon as we get done here, I am out until Tuesday, the 3rd or 4th. So just wanted to let you know that.
Disconnect her now.
Thanks, everybody.
All right, thanks a lot, Michelle.
Thank you.
Thank you, Michelle.
Okay, if we had other business, we would take a quick break now, but we don't have any education or board reports, any old business or any new business. Is there anything else for the good of the order before we move on to executive session? How long do you need to?
Half an hour.
All right.
It's on him.
All right, so let's take a 7-minute break until 7:25. And then we will get together, let's say 35 minutes, just so we can make it even. We'll go to 8 o'clock then after executive session. So we will recess into executive session to discuss real estate and personnel under the appropriate RCW. We don't, do we anticipate any action?
We do not anticipate action.
We don't anticipate any action. Thank you all for coming.
Joining us for that.
Yeah,
Dr. Martin and Mandy, can you stay at the top of and Jason?
all right. Thank you all for coming. We'll then go into break and then to executive session and reconvene into public session.
Thank you.
8 o'clock. Thank you.
Welcome, Wayne.
Yep, thanks, everybody.